Well, hello and welcome to this live virtual forum on the COVID-19 vaccine and what Oklahomans might expect in weeks and months to come as distribution is expected to begin shortly. My name is Ben Felder with the Frontier. I'm speaking to you from the Frontier's office in Oklahoma City. My colleague, Cassie McClung, who covers healthcare for the Frontier, is at our office in Tulsa. And also in Tulsa is the Frontier's editor-in-chief, Dylan Goforth, who is producing today's broadcast. And today we have three experts to talk about the vaccine and hopes of answering some of the biggest questions we all have. We'll introduce our three guests in a moment, but first a few housekeeping items. Throughout this panel, which will last about 55 minutes, viewers are invited to submit questions in the Frontier's Facebook feed. After our initial conversation, we'll turn over to some of your questions to make sure that we're hitting on the issues that matter most to you. If you're unable to stay for the entire panel, be sure to look for the full video, which we will post on our Facebook page and online at readfrontier.org later today. Maybe you're a regular reader of the Frontier, and if so, thanks for joining us. Well, we hope that this will be the first of many live virtual discussions moving forward. Maybe this is your first time becoming familiar with the Frontier and you've just stumbled across us, and we want to welcome you. We are a nonprofit news organization. We rely on the support of readers like you. And maybe you also are one of our donors, and we want to thank you for your support. So since March, when the first case of COVID-19 arrived in Oklahoma, we mobilized much of our coverage around this health crisis, the state's response, and its impact on Oklahomans. As cases have skyrocketed in recent months, with health officials predicting more hospitalizations and deaths to come, these are some very tough times. But the news that vaccines are becoming available and may soon be ready for limited use in Oklahoma is definitely a reason for hope. Obviously, the vaccine's arrival won't be a magic wand that instantly ends this pandemic. The state has to secure doses, execute a plan to distribute it, and work with hundreds of healthcare partners around the state. Cassie McClung has been kind of our powerhouse reporter on the coronavirus this past year, covering the crisis facing hospitals and long-term care facilities, the state's effort to provide PPE, and the coming vaccine. Cassie, we recently learned that the state expects the first doses to arrive in a matter of days, maybe even sooner. What's the latest on when the first dose might arrive in Oklahoma?
Right, so the health department expects an initial shipment of around 30,000 doses of a vaccine sometime next week. And those will be prioritized to certain groups, but we can jump into that a little bit more here in a few minutes.
Yeah, definitely an exciting time, but a lot of questions to go with it. And I think today we're going to find some of those answers. Cassie, I'm going to go ahead and turn it over to you to introduce our guests and see what we can learn about the arrival of a COVID-19 vaccine in Oklahoma.
All right, great. First, thank you all so much for taking the time to be here and answer questions on the upcoming coronavirus vaccinations. We have three experts with us today. We have Dr. Eliza Chakravarty, who is an associate member of the Arthritis in Clinical Immunology Research Program at the Oklahoma Medical Research Foundation. We also have Dr. Jared Taylor, who is serving as the state's epidemiologist. And finally, we have Dr. Douglas Drevets, Chief of Infectious Diseases at OU Health. Thank you again, doctors. I'm going to go ahead and dive right in with my first question. Dr. Drevets, I'll start with you. Can you tell us which vaccines are expected to be available in Oklahoma and when?
So presumably, the first one will be the Pfizer product, which was made in combination with the German firm BioNTech. The second one will be the Moderna product. The Pfizer product is having its, so to speak, day at the FDA tomorrow, where they will have their vote on it, and then it will presumably be shipped out to the states, assuming that it gets approval for emergency use. The Moderna product will have its day for hearing a week later, and then again, presumably, if it receives emergency use authorization, it will then be shipped relatively rapidly out to the states.
Okay, thank you. Can you tell us a little bit about how the vaccines are administered?
So these are both intramuscular vaccines, and that sounds horrible, but it's the same way that the flu vaccine every year is administered. It generally goes into your shoulder and the deltoid muscle with a needle that's based upon sort of your body size. And so it's not anything special in that sense, goes right into the muscle.
All right, thank you very much, Dr. Drevets. Dr. Taylor, to you, this is a multi-part question. First, can you tell us a little bit about why it's important for Oklahomans to get vaccinated?
Yes, so there's the SARS-CoV-2, the causative agent of the COVID disease, is novel. And so no one prior to this year had immunity to it. And that means that we're all, as best as has been shown to this point, we were all susceptible to it. And the only way that we get to the point that transmission is not an ongoing problem is to achieve adequate immunity, what may sometimes be referred to as herd immunity, such that the likelihood of a susceptible individual bumping into an infectious individual is relatively low. The reason that that's so important, and that we can't go to more, almost routine control measures such as just looking out for those individuals who have symptoms, is because we know that asymptomatic individuals play a notable role in transmission of this virus as well. So we're all susceptible. We're potentially capable of transmitting it even in the absence of symptoms and knowing that you have it otherwise. And so really the only way to get this under control is to get adequate immunity across the population. And certainly there's been some folks who've spoken about achieving herd immunity through natural exposure and natural infection. We are seeing through serologic surveys of the state and even across the country is, and honestly across the world, is that such aspiration would bring tremendous intolerable costs, or what I would hope would be intolerable for most reasonable persons. We're probably at an exposure rate in the state of Oklahoma of about 1 in 5 people, and we would have to be at least triple that to have any hope of really containing it. And then we also don't know about the length of immunity and robustness of the immunity conferred following natural exposure. We, to some extent, don't know about the length, duration, and robustness of the immunity following vaccination either, but some of the preliminary work has been very reassuring that somewhat uniquely, but not unheard of, it's very possible that the vaccine will actually provide better and longer immunity than natural exposure. So the vaccine is definitely the preferred route for us to go to try to protect the citizens of our state.
Okay, thank you. So how much will this vaccine cost for Oklahomans who are seeking to get it?
So at this point, there will be no cost. Of course, there's no such thing as a free lunch, but this has been born through investments in development and purchase and acquisition at the federal level. And these allotments are being coordinated through federal provisions that account for that cost. And so there are systemic costs within the state in terms of we're going to have facilities and personnel who are administering it. We as an agency of the OSDH is going to be bearing those costs. And so the citizens will be able to get these vaccines without any direct cost to them.
Okay, so as far as the general public having access to this vaccine, what kind of timeline are we looking at?
That is still undetermined. In the grand scheme of things, that goes to what you mentioned at the outset. We have this prioritization of recipients, and when we get down to the various tiers, which would include the general public, is largely going to depend upon how quickly the manufacturers can continue to replenish the supplies, as well as what uptake we have among our citizens in the priority groups ranking above. And so if we get very strong uptake among our healthcare workers and then into our long-term care residents, which are going to be the priority 1 recipients, then we're going to use up more of our dose allocation. If we're not as successful in getting those individuals into the vaccination program, then we would have more vaccines available to distribute to the lower tiers sooner. But we don't want that. We actually want to get everyone throughout all of the tiers taking the vaccine as soon as it's available to them.
Thank you, Dr. Taylor. I'm going to switch over to Dr. Chakravarty. Let's talk about safety a little bit. Some people are worried coronavirus vaccinations won't be safe and that the development was rushed. Can you talk a little bit about what goes into approving a vaccine? Could anything go out that was unsafe? And is there any reason to believe that this vaccine might have more risk than any other?
Those are great questions. So the key thing I think to remember is that vaccines have been an integral part of public health for decades. And so that there are actually very structured mechanisms for reviewing vaccine research for safety and efficacy. So that, yes, the timeline has been accelerated for this vaccine, but it is not due to cutting corners. It's due to we had a couple of head starts as far as developing the vaccine. People have been working on this new technology for a long time. We've known other coronaviruses that have helped us identify which parts of the virus are going to make the best immune response. And we got the exact genetic structure of the virus in January, so that we had some head starts in order to make this particular vaccine. And we had a tremendous investment so that the finances were there and people were working on all aspects of the research and the development of the vaccine. So yes, it's accelerated, but it's not due to corners being cut. And so, the studies that are before the FDA right now and have been reviewed in England and other things like that, they have had pretty standard numbers of participants receiving the vaccine. So an order of 40 and 50,000 for each vaccine that's under development. And so that's what we see with the shingles vaccine, and that's what we see with other vaccines. So yes, it's accelerated, but the mechanisms to evaluate safety and efficacy are rigorous and are in place and are not going to be violated. The way I think about it is the independent folks reviewing all this data are looking at it for public health, but they're also looking at it, would I give this, would I let my children have this? Would I ask my parents to have this? Would I take this myself? So accelerated, but not rushed, if that makes sense.
That does make sense. Thank you for that, Dr. Chakravarty. I'm going to circle back to Dr. Drevets now. Dr. Drevets, how well are these vaccines supposed to work? And do we know whether they offer any long-term protection?
So the data that has been released so far show that they work really, really well in terms of a vaccine response. And both the Moderna product and the Pfizer product appear to be around 95% effective in preventing infection. And so, if you keep the number around 90 to 95% in, good, that's probably where they're going to land. And this is in contrast to other vaccines, such as the yearly flu vaccine, which we all take, which can be anywhere from 40 to 60% effective depending upon the year. And so they seem to be really quite good, or as the scientific community likes to say, robust immune responses. Now, obviously, since the trials started in July, you don't have 1 year or 2 year follow-up on these data yet to see how long the immune response lasts. There is a paper out looking at the Moderna product where they did have a cadre of folks that were immunized early in a phase 1 or 2 study, and they did have 6-month follow-up on those individuals, and many of them had just as robust immune responses as did folks who had had natural infection. And so I think even though the data aren't out and this story is still being written, we can have a reasonable degree of hope that the vaccine will provide immunity for more than a year perhaps 3 years, maybe 5, maybe longer. We can always hope for better, but it seems to be a very good product at this point.
Okay, and Dr. Drevets, I've been seeing this question a lot. How quickly could a vaccine end this pandemic?
So the answer to every question like that is it depends. And it depends on how fast it gets distributed, how many people say they will take it. And then it also depends on how fast the virus continues to circulate in the community and people continue to get natural infection and build up immunity that way. With some modeling studies, I think we can be hopeful that we can start seeing serious declines in new infections by the late winter, perhaps earlier, but that would be my hope. And that could be in the February to March range, and that could be due to multiple factors. One would be vaccination. One would be just the virus is naturally infecting people and they're becoming immune to it. And the third one would be that, we're still hopeful that this coronavirus will also show some seasonal pattern like other coronaviruses do, and that when the weather warms up and becomes more humid in the spring, the virus will be less persistent in the environment, and that will give us an advantage there.
All right, thank you very much. Dr. Taylor, this is a multi-part question for you. State officials have said that rolling out this vaccine is going to be a huge effort. What percentage of Oklahomans does the state hope to get vaccinated, and how does the state plan to hit that target?
Well, I mean, I think that the easiest answer is we hope to get as many as possible, right? This is, we hope to employ a multi-pronged effort to maximize that number. We're committed to making available, all the doses that we receive and distributing that as efficiently and effectively as possible. Ultimately, it is going to be voluntary. And so, we are just, I think it would be fairest to characterize that we're going to vaccinate as many as possible from the medical perspective, building on what Dr. Drevets just addressed there. What percentage do we need to end the pandemic? I mean, it sort of becomes, what do you mean by that, right? Do you simply mean getting to the point to where we're no longer worried about exceeding hospital capacity? Are you talking about getting to the point where, we can approach more normality in our lives? Or are you talking about the point where we've eradicated SARS-CoV-2? Those are all different targets, and they're all going to have different steps that would be required in order to get there. And so the higher the number as far as getting them into arms, the better. We've already been engaging in a variety of communication efforts. We're going to continue to do that. This forum, we're very appreciative of the opportunity to be speaking here. We've obviously been coordinating very closely with all of our healthcare providers who are in that first tier priority group for immunization. We know that they are very much aware and abreast of the science of all topics related to COVID, not least of which being the vaccine. And so we're confident that there will be good uptake there. We've been working closely with our long-term care facility providers as well since the beginning. It was very unfortunate just how devastating this virus was to those facilities and their residents early in the pandemic. And so they understand the significance of this. And we've built a great collaborative and supportive relationship with them. And so we're going to build on that as we roll this out. Obviously, the harder lift comes in as we spin out to those other priority groups. We've had a great deal of interest from the governor's office down through the educational groups and everyone in between to prioritize teachers as an example. We hope to do that. We would love to do that, but ultimately it depends upon the teachers. And we want to answer their questions, reassure them. All the information that's just been provided about the safety and the efficacy of the vaccine hopefully brings them along. But it's just going to come down to the individuals choosing to pursue this when it's made available to them.
Right, that makes sense. And you mentioned trying to get that messaging out there and working with different groups and organizations, and it ultimately being left up to the individual. So I guess how big is vaccine skepticism a concern to rolling out this vaccine and making sure enough people take it to where it's effective?
That's certainly a concern, and something that we're combating every day and at every opportunity that's provided to us. Um, I feel there's going to be a minority. It tends to be a vocal minority, but I think a relatively small minority who are just not going to be open to the prospect of receiving a vaccine or vaccinating their family members at all. And there's probably not much utility in investing time and resources in trying to convince them otherwise. I think the majority of Oklahomans and indeed Americans are open to considering receiving this vaccine. They just want to be reassured and I'm sure there's a certain degree of hesitancy to not be the first persons and sort of a misperception there of being a guinea pig. But I mean, we respect that and understand that. And so the fact that we're rolling out with our healthcare providers up front, I think is going to be beneficial in that regard. But we certainly want to publicize the uptake and the comfort of those individuals from leadership on down through our frontline workers having this. At the same time, we don't want to dismiss or minimize the legitimate concerns, right? And one thing there is to say everything has risks. When you get out of bed in the morning, you're taking a risk, right? When you drive to work or whatever, there are risks involved with any activity, and that includes vaccine uptake. The outcomes that we're seeing in the trial were for those risks. The outcomes tended to be extremely minimal and should not in any way discourage folks from taking it. But we want to be honest about that. We want to make folks aware that there may be what would be perceived as side effects. Those typically mean simply that the vaccine is working. It's achieving what we want it to achieve. And so we want people to understand that. It's not that the vaccine gave them the infection or gave them the virus. When they ache and when they get, feel not great and a little lethargic and maybe even develop a fever, that's okay. That's again, the body's responding to that vaccine and being prepared for when they encounter the real virus. So I think that's our goals, is to be empathetic to those concerns, to try to address them reasonably, and have confidence in the judgment of Oklahomans in weighing those balances and risks, benefits and risks.
Thank you, Dr. Taylor. And Dr. Chakravarty, this kind of goes into what Dr. Taylor was just saying about people being concerned about side effects. So I guess, can you tell us a little bit about what kind of side effects might be associated with either the first or the second dose of these vaccinations?
So as far as my understanding goes, there weren't any surprises in the studies. And again, remember, these studies were tens of thousands of people. There weren't any surprises about the side effects or effects of the vaccination. And those we see typically with any vaccine. And so it's just like Dr. Taylor said, where people will feel some soreness, some redness, feel achy, feel kind of fluish, and have some fever. And that's just, again, it's not the virus. It's actually your immune system working well and making a good response to the vaccine. So we expect that. And in the studies, it's been shown to be, as far as I know, again, about similar to what you might see in other vaccines. And it's important to remember too that no vaccines that have come far in the process, especially the first two, contain any actual virus particles. So these vaccines are designed in a lab. There's no actual virus in it. So there's no way to actually get the virus from the vaccine.
Okay, and that kind of touches on my next question. There's people who are concerned that after getting vaccinated, they might be contagious, and it sounds like that's not the case.
No, because there's no vaccine in it. Now, people may have been exposed and and actually have the infection around the same time that they got vaccinated. So that I think even if we've been vaccinated, we still need to remember that we could have, before our immune system, our immune response is robust and strong and protective, we may still be contagious, we may still be susceptible, and we may still pass it on to people. So the important thing to know is that you can't get it from the vaccine, but you can still get it separately around the time you're vaccinated. So having had, particularly if you've only had one of the series, you may still be contagious just from being alive and in the community. So we need to keep up with all of our other practices as far as mask wearing and physical distancing and things like that. But you cannot get it directly from the vaccine itself.
Okay, and then if someone knows that they've had COVID-19 before, should they still get a vaccine?
Yes, their recommendation is that people should get the vaccine, even if they've had COVID before, for a couple of reasons. Number one, when people have had the infection, I think there's probably a lot of variety in how strong the immune response and how long lasting it is. So that getting the vaccine will only enhance the immune response, even on top of a natural immune response. In some of the studies, they were able to look back and see whether some of the participants in the studies had actually been exposed to the virus in the past before getting the vaccine, and the outcomes were not different. There were no safety concerns. It's not going to be dangerous to get the vaccine if you've been infected, but it really can only help boost your immune response. So we're recommending that everybody receive the vaccine, whether or not they think or know that they've had the infection before.
Okay, thank you, Dr. Chakravarty. Dr. Taylor, I think this is my last question before we go on to reader questions. So we're talking about the initial rollout of the vaccines, and I know, we talked about there's still a lot of unknowns about how long the immune from the vaccine might last, but does the state expect that, coronavirus vaccine will be something people need to get annually, like the seasonal flu vaccine?
I believe Dr. Drevets spoke to this earlier, and certainly would defer to him if if he would want to repeat that or have anything different. I think what we would be saying is the science is quite early in that. Our focus at this point is to get the initial vaccination and the required booster into folks. Allow the science to catch up on that and issue the guidance from CDC and even the manufacturers in terms of duration of immunity, and make those decisions later. I think as Dr. Drevets spoke to earlier, I think the science indicates right now that immunity is actually going to be pretty robust and hopefully reasonably long-lived, and probably not something that requires an annual booster. It's important to recognize that the primary reason that we require an annual flu booster, a booster for influenza or annual vaccination for influenza, is not that the immune response wanes, right? It's that the virus changes that dramatically. And we saw this a handful of years ago. I lose track of time, so I don't remember when it was. Maybe someone else has that. But, there was an influenza strain that came through that actually had relatively lower morbidity and mortality than expected among the older population. And it was determined that was because it was very similar to a virus that had circulated decades earlier. And so even for something like influenza, the immune system has a good ability to maintain a memory. Now that's not always true. That the common cold virus, we don't retain a very good memory to, but it's not very invasive. It stays local and those kind of things. And so it's reasonable to believe that we're going to have a lengthy residual impacts of this vaccine. But it remains what the final recommendations are remain to be determined based upon the science.
Okay, thank you, Dr. Taylor. I think that's all the questions I'll have for you all. I'll go ahead and hand it back over to Ben for our reader questions.
Yeah, thanks, Cassie, and thanks to our panelists. That was some really great insight. We do have quite a bit of reader questions, and I've kind of been going through trying to hit on the ones that are most commonly asked here for the kind of final 20 minutes of this program. I'm going to defer to the experts that we have for anybody who wants to answer this question, but this might be more tailored or more directed to Dr. Taylor. And a lot of people are asking about a second dose. So this is a 2-dose vaccine. What happens if someone misses the second dose? And then what's the process for getting people to come back for that second dose?
So again, I'll be glad to defer to Dr. Drevets if he wants to speak, or Chakravarty as well, if to some of the specifics on this. Like with all of this, there's a lot that remains to be determined. These vaccines were investigated with very specific booster times, and so that's what is coming out as the advisement, and we want to follow that as closely as possible, and we would certainly encourage Oklahomans to abide by that. That being said, we don't want to become a slave to silliness, right? I mean, if you say, well, the booster is supposed to be in 21 days, well, does that need to be to the AM, PM? Does that need to be the exact hour? What if you got it, really, let's get it within that reasonable time period, and the immune system's going to do what the immune system does very well. The evidence that I've seen so far is that there is a benefit to actually only receiving 1 dose. We don't want to stop there. We want people to get the booster because it gets better following that booster vaccination. But we don't want folks to delay getting a vaccine because they're not necessarily going to be able to come back exactly 21 days later or 28 days later, depending on which product you're using. And let's work out those logistics, for the individual as we go through. To your point, what I can speak to definitively in regards to the state is it actually is a pretty heavy logistical lift to figure out that boostering requirement, because if you get the Pfizer vaccine up front, you need to get the Pfizer booster. We don't want you to get the Pfizer vaccine at the first time and the Moderna vaccine at the second, or vice versa. And so we within the agency are working on developing systems that are going to keep track of who received what vaccine product at what time. Excuse me. And we will, we'll be in charge of tracking that and making that information available to the patients, and working with them to schedule those follow-up appointments to get boosted at the interval that's appropriate for them for the product that they received. We're also working with the manufacturers when we talk about 30,000 doses of the Pfizer vaccine rolling out. We've been assured that there will be 30,000 booster doses coming at the appropriate interval following that. And so we don't need to hold half of those vaccines back with the intention of boostering. We're going to go ahead and get as many of those in to our patients as possible, and trust that the system will get the boosters to us. So there is a tremendous logistic lift going on. We've been invested in that since September, and we feel very comfortable that we're going to have a system in place that will allow us to do that as the time comes.
Right, let me jump in. I think more than likely when you get your first dose of vaccine, you will then make an appointment for your second dose of vaccine, and that way it will be the same product at the proper interval. And I agree with Dr. Taylor. The studies were done in a very particular fashion at a very particular interval between the 2 doses, 21 and 28 days. In practicality, can you go 22 days and have it be just as good as 21? Yes, probably. We do want to stick as closely as possible to the recommendations, but have a little bit of room in there for wisdom and flexibility. But again, we're all waiting for the guidance from the FDA on that particular item.
Great, thank you. Well, once again, I'm going to ask a question, and I'm going to defer to our panelists, whoever would like to kind of jump in, or if we have multiple who would like to answer, that would be great. We have a lot of people who want to know how to go about getting vaccinated if they're immunocompromised and where they fall in the state's priority plan. Specifically, will immunocompromised persons who are on a immunosuppressant biologic drug be able to safely take a vaccine once it's available to the public? and without having to temporarily discontinue their prescribed medication? So kind of a mouthful question there, but one that we've gotten a lot.
I think I'll jump in there because I deal with immunosuppressed people all the time. And this is another one where we sort of need to wait and see. We don't have a lot of data on vaccine responses in people who are severely immunocompromised due to an underlying disease or their medications. But one thing we do know is that, again, the vaccine doesn't contain any live virus. So in the past, for example, with the early shingles vaccine, not the current shingles vaccine, it was a live attenuated virus. So we were worried that people with immunocompromised conditions may be at higher risk of getting the actual virus from the vaccine. That is not the case for this vaccine. But we need to remember that these are all initial studies we're basing it on, so it's relatively healthy adults. They haven't been focused studies performed yet on particular populations such as pregnant women or people who are immunocompromised and that kind of a thing. So right now, there doesn't appear to be a risk to getting the vaccine if you're immunocompromised. There's no risk of, again, getting the infection from the vaccine itself. What we don't know is how strong the immune response is going to be if depending on the underlying condition or the medication.
Great, thank you.
I would say,
go ahead.
Yeah, it's also safe for folks with HIV and many other conditions, lymphomas, chemotherapy, as well as biological agents for arthritis and things. So this will be something that we want everybody to take.
Great, thank you. We have a lot of parents who are asking questions about vaccinating their children. One, when do we expect kids to have access to the vaccine? And then two, do we know anything about how this acts with children?
So the data that's been released by Pfizer, and I only had a few hours of interrupted time to look at that. They did have a cohort of adolescents in that age group or in that trial, several hundred, I think, or maybe up to 1,000 of folks below the age of 16. I think between 12 and 16, and they tended to respond just as well. They had a few more local side effects, I think, than did the older age group, but it would still be deemed safe. At this point, there's no other information available about younger children and what to do. So I think that'll be forthcoming also from FDA.
Great. This is we've kind of talked about the known side effects and kind of the unknown part of this, but a lot of people are kind of asking about practically how should they structure their days after getting the vaccine? Some are asking, should I plan to take the day off of work that day, or could I, because of some possible side effects or how I might feel? It sounds like there's still a lot of unknown around that, but what kind of advice would you say to people who are kind of concerned just about what that next day or two would be like after taking the first dose?
So this is, again, somewhat speculative because the data are just coming out. Most of the reactions were considered mild to moderate. And in the language of the clinical trials, that means they weren't severe enough to interrupt anybody's acts of daily living or their job. And I think less than 10% of the reactions were considered severe, so to speak, where you might have to stop working or stay at home. So the vast majority of people will be able to carry on with minor inconvenience. Probably not unlike receiving other vaccines such as Shingrix or some of the high-dose flu vaccine. So, but again, I think we'll get much more data from this when it's all released in the next week.
Great, yeah, thank you. Dr. Taylor, this might be a question kind of directed to you. Once we get to phase 2, how will the state and healthcare organizations identify and contact qualifying patients? I believe those that are 65 and older or those who have underlying conditions are part of that phase. Correct me if I'm wrong, but will this be delegated to the discretion of the enrollment providers, or will the state kind of commandeer this process?
I'm not sure that I can speak fully to that question. That we've got a team of folks who've been, just dedicated basically nonstop to the logistics of this, and I've not heard that question in my, I wouldn't say peripheral involvement, but not necessarily integrally and in full depth involvement in that planning. I think at that point, it's largely my anticipation is that it's going to be a cooperative effort. I mean, it's going to be a matter of us communicating with the population and making them aware of where we're at and working closely with our providers because, there's not, just because we enter into stage 2 or tier 2 doesn't mean that we're still not going to be providing it for tier 1 persons who didn't get vaccinated or whatever. So it's sort of going to become this, adaptive rolling process where we're going to certainly abide by the priorities that we've established, but have enough flexibility that we can continue to provide the most good for all the individuals. So I don't think we have any intention of commandeering this, so to speak, and going in and trying to apply rigorous criteria ourselves. We're going to count on our partners who are assisting. Obviously, some of the vaccination is going to be done by our department at the county health departments, but we're going to have lots of other partners who are participating as well, and we're going to be respecting their judgment and following the criteria and prioritization that we've laid out as well.
Great. Dr. Drevets, earlier in our panel, you kind of answered this question, but it was kind of near the top, and we're getting this question asked a lot, so there might have been some people who had missed it or would like a little bit more detail. But can you just kind of explain once again kind of the logistical process of receiving the vaccine? Where will the shot be administered? How will it be administered? Kind of what's the process for healthcare professionals? I mean, what kind of training are they going to receive, or what information will they receive in terms of actually administering the shot or the vaccine to individuals?
So it will be like most other vaccines. There will be very specific product information that is released by the manufacturer in accord with FDA regulations, showing them exactly, how to pre-fill the syringe, how to treat the vaccine, when to thaw it, how long you can store it, and many other things. There will also be information on the size and the shape and the bore of the needle. As I mentioned earlier, this is both the Pfizer product and the Moderna product are also our intramuscular vaccines. This is the same way that you receive the flu vaccine. It's in the muscle, and most of the time it's given in the shoulder muscle, in the deltoid muscle. Beyond that, I think we just wait for the guidance. But in general, there won't be anything, more than likely anything special about this, unless there's a special injection device. And again, that waits to be seen as to what's the manufacturer puts out, and everybody will be trained on that.
Great, thank you. Just a couple more questions as we kind of hit the home stretch here, and thank you guys so much for your time. This has been very beneficial. Another question that we kind of referenced earlier, but we're still getting a lot of is, what do we know about being able to continue to spread the coronavirus after being vaccinated? Should people who get that first dose, still be participating in social distancing practices, and just kind of what do we know about the potential spread after being vaccinated?
So in the studies that were done, they looked at symptomatic cases of coronavirus. So you had to have symptoms, at least one or more symptoms of coronavirus, and then a positive coronavirus test. The manufacturers did not assess the efficacy or how well the vaccine worked on this whole issue of asymptomatic spread. And in infectious diseases parlance, we call that carriage. And it's the idea that there are many germs that we can carry up in our nasal passages that don't infect us, but yet we make antibodies too. And this is how we get immune to things in the environment. And again, this is a well-known process. So it's just not yet known if folks who receive the vaccine can also at least harbor or carry the virus up in their nasal passages, even if they don't have symptoms. The hope would be, and the presumption is, that because the vaccine prevents people from actually getting sick, in general, people who are ill are going to have higher amounts than people who are not getting ill. And more than likely, people who get vaccinated are going to have lower amounts than people who have never been vaccinated. That said, this is just one of those things. We're doing these, we're walking through this in real time, and we'll just have to see. So my advice is to continue to participate in masking where appropriate and social distancing.
I would echo that. I mean, I think it's also important to recognize that it does take time for the immune system to process the vaccine and to make a robust response, so that being vaccinated doesn't instantly provide protection. It does take a series of weeks to months even. And we need to be cognizant of that, so that we still may be partially susceptible for some time after we've received the full vaccine dose.
That's right. You shouldn't have the idea that you can get the vaccine at 4 o'clock and then go out and party all night because you're immune. It doesn't work that way.
Great. Well, thank you. This has been incredibly informative. Obviously, as we've said, there are still a lot of unknowns, but I really appreciate you guys offering some specific answers that we do know as we kind of prepare for this kind of new chapter of this pandemic. That's going to do it for today's live panel discussion. I want to say a big thanks to our 3 experts who took time out of their very busy schedules to be with us. And if we were in person, this would be the moment that I'd ask everyone to join me in giving a round of applause and thanks. So we'll just kind of mentally hear that applause in our head. But once again, this video is going to be posted on the Frontier's Facebook page and online on our website at readfrontier.org. Just real quick, I have 3 quick invitations to offer those who are still watching. First, be sure to follow our ongoing coverage of COVID-19 and the coming vaccine. You can find all of our journalism once again at readfrontier.org. Second, I strongly encourage you to sign up for Cassie's weekly health newsletter, Health Matters. You can find a link to sign up on our website, and I'm sure there's also a link in Cassie's Twitter feed as well. And finally, if this is the type of journalism that you value and would like to see more live forums like this one, I invite you to consider making a donation to the Frontier. We're a nonprofit news organization, and even a few dollars a month goes a long way in making our work possible. We really couldn't do it without you, so thank you. Thanks again for joining us today. For the Frontier, I'm Ben Felder. Thanks again to our panelists. Everyone stay safe and healthy, and have a great rest of your day.